Dear students, good morning. Today I'm going to give you a brief idea on gastric neoplasms. There are different types of gastric tumors. They range from small benign lesions, big benign lesions, small malignant lesions to big malignant ones. The behavior of the malignant neoplasm varies greatly from low malignant to aggressively malignant tumors. So diagnosis and management will differ for each type as well as the prognosis. Gastric tumors may arise from the tissues of the gastric mucosa. These are the neoplastic polyps or the adenocarcinoma, or the connective tissue of the stomach wall. These tumors were previously known as leiomyoma or leiomyosarcoma, but now they are considered a part of the spectrum of a disease called gastrointestinal stromal tumors or GIST. They rarely arise also from the neuroendocrine tissue. These are the carcinoid tumors, or from the lymphoid tissue. These are the lymphomas. The commonest is gastric adenocarcinoma, and unfortunately it has a poor prognosis. These tumors may be benign or malignant, as we said. Some of the benign ones may turn malignant after some time, like the neoplastic polyps or the adenomas. Others do not turn malignant, like the hyperplastic polyps of the stomach. Also, benign GIST may increase in size and acquire malignant behavior. Gastric neoplasms are usually silent in the start, and when symptoms appear, this indicates advanced disease. The delay in the diagnosis is due to three reasons. The first is the large capacity of the stomach volume, so obstruction will occur late, if any. Also, the symptoms mimics other causes of dyspepsia, like peptic ulcer and other diseases in the stomach and duodenum. And the last one, that the presentation of a mass in the epigastrum is only felt clinically to be palpable in big masses like in GIST, because the stomach is hidden behind the lower ribs. Early cases are diagnosed usually accidentally during investigations for other conditions of dyspepsia or other abdominal conditions, or during screening, which is performed routinely in countries like Japan, where gastric carcinoma is common. It is diagnosed by upper gastrointestinal endoscopy, which is the main tool for diagnosis. Upper endoscopy is done either to diagnose or to rule out gastric neoplasm. The rest of the investigations help in staging of the disease. However, abdominal CT may diagnose GIST when it is large enough. Each type of neoplasm should be managed according to its own type, as the response to the different lines of treatment differs in each type, and also in the different stages of the single type. Surgery is the main line of treatment in early adenocarcinoma and GIST, while chemotherapy is the main treatment for lymphoma. Surgery is required in the majority of cases and is the only hope for cure in early adenocarcinoma and GIST. Combining chemotherapy with surgery gave better results, especially in lymphoma and GIST. So they are used in combination, either preoperative, postoperative, or both. However, in adenocarcinoma recently, chemotherapy is used with surgery. As we said, surgery is required in the majority of cases and is the only hope for cure in early adenocarcinoma and GIST. The combination is now used in all the malignant gastric neoplasms. When you use the chemotherapy before the operation, it is called neoadjuvant therapy, while that used after the operation is called the adjuvant therapy. The triple therapy is the adjuvant, the operation, and the neoadjuvant before the operation. In advanced cases of GIST, the chemotherapy is used before the operation to reduce the activity and maybe the size of the tumor, rendering the operation easier and the excision smaller. Further discussion will be in the face-to-face presentation and lecture, and please be ready with your questions in the next face-to-face session.